As we begin our discussion of quality improvement in healthcare, you may be wondering why, as an emergency physician, you need to know this stuff. And I think a story is always helpful to illustrate why we need to reach beyond our current skills and learn some new tricks in order to make our practice better. I wanted to share with you the story of Josie King. Josie is an 18-month-old female whose parents had recently moved into a new house outside of Baltimore, Maryland in the early winter of 2001. Being an old country farmhouse, they were beginning to do some home improvements on it, and as such, they didn't have too much of a kitchen. So that evening, as they were getting their dinner prepared, the kids disappeared upstairs to play. Her parents didn't think too much of it until they heard a scream that just shook the house. They rushed upstairs to see what was wrong, and they found Josie standing beside the clawfoot tub crying. Apparently, earlier in the day, Josie's siblings or another family member had been playing with her, floating some toys in the water, and she wanted to see it again. But unfortunately, she had turned on the hot water, and as they would later learn, the hot water heater at the time was faulty, and so the water that was coming out of the faucet was near boiling. Josie sustained burns over 60% of her body, a pretty critical injury for any patient. They called 911 and she was rushed to the nearest burn center and from there to the pediatric intensive care unit at the Johns Hopkins Hospital. She received the best burn care that she could possibly get: IVs, fluid resuscitation. She was placed on a ventilator. A few days later, the IVs would be exchanged for a central venous catheter. Over time, she actually seemed to do pretty well. She was taken off the ventilator, seemed to be able to eat again, and then just before Valentine's Day of 2001, she was ready to be moved out of the intensive care unit to a step-down unit. Unfortunately, as soon as this occurred, she started to have a fever and then began to vomit regularly. It turned out that the central line that had been placed in the intensive care unit had become infected. But because she had been doing so well, they elected to remove the line, and instead of putting in a new peripheral IV due to all of the scar tissue, they used oral antibiotics instead. All reasonable therapies. Unfortunately, Josie continued to have vomiting and then developed diarrhea, a well-known complication to any oral antibiotics. Thinking that she was going to be going home before too long, they still didn't make any efforts to reinsert a peripheral IV, partly again because of the scarring, and partly because they thought that she was doing okay and would be going home. Unfortunately, Josie just seemed to be getting more and more dehydrated, and this was missed by the care providers. Josie's mother was quick to ask caregivers if they could give Josie some fluids, just because Josie seemed to be so thirsty. Unfortunately, they were afraid with the vomiting that the fluids would only make her worse, and so they only gave her ice chips. They continued to check her vitals, which, for the most part, seemed fine. Unfortunately, as her mother gave her a bath one evening, she noted that Josie just kept sucking on a washcloth trying to get a drink. And then as Josie's mother put her to bed that evening, it seemed like Josie's eyes were sunken and rolled back into her head. She tried to summon help, but didn't feel that she was taken seriously. The physicians never came to the bedside to reassess Josie. Now, we all know that kids have amazing compensatory physiology, and they seem to hold on till the very end. And that's what seemed to be happening with Josie. The next morning, when her mother went to get her up, she was unresponsive. This time, Josie's mother ran out into the hallway and forced the rounding team to come into the bedside. At first, they actually tried to dismiss her and called her mom. But Josie's mother prevailed, brought them to the bedside, and they began to assess Josie immediately. Since Josie had had a pretty severe burn, back in the intensive care unit, she had had a pain pump inserted, which was later discontinued in exchange for methadone, as they attempted to wean her off of the pain medicines. Thinking that it may have been the methadone, the care team gave her Narcan, and Josie actually seemed to perk up. Since she woke up, the team at that point didn't really look further to see if something else could be happening. Fortunately, this day they did allow her to drink, and she seemed to be doing okay. Unfortunately, what happened with the Narcan was it likely just served to relax the vasodilation that can happen with opiates as well as with sepsis. And so they partly missed the sepsis that was occurring. They essentially missed the canary in the coal mine. Later that evening, they decided they were going to try a half dose of the methadone. And just as it was being given to Josie, her eyes rolled back into her head as she went into cardiac arrest. Like any cardiac arrest, there was a flurry of activity, and the resuscitation progressed. They were able to regain spontaneous circulation, but unfortunately, by that point, Josie had been anoxic for too long. On February 22nd, 2001, Josie died. Josie's death was due to medical error. The story is tragic, but there's a bigger tragedy. And that's that Josie's story is not isolated. We all know a Josie. Any physician who's practiced long enough has seen mistakes made and patients harmed by those same mistakes. It is something that has gone silent for far too long in healthcare. In 2000, the Institute of Medicine released a report titled "To Err is Human." At the time this was released, I was a senior in college. My father actually received the book and showed it to me when it was hot off the press. He said that it was a book that I needed to read. 13 years later now, I'm only beginning to understand how right he was. And that book now sits on my desk. The report outlined the fact that somewhere between 44,000 to 98,000 deaths per year are due to medical error. This means that medical error kills more patients than motor vehicle accidents, breast cancer, and AIDS combined. That's a pretty staggering number. And that's the deaths. That's not even taking into account the injuries, the morbidity, so to speak, of the people who need more care, repeat testing, or other duplicative work. Now, On the bright side, in the 13 years since that report was published, we've seen a significant amount of work being done trying to improve the system that we work in. We've seen initiatives in hospitals across the country. We've seen medical school curricula. We have seen new organizations being formed. Yet, despite all of these initiatives, last year the New England Journal of Medicine released a report by Landrigan et al. Titled Temporal Trends in the Rates of Patient Harm Resulting from Medical Care. They looked at a 5-year period and found that there was no significant decrease in the overall rate of harm. While this may not surprise you, it was pretty interesting because the study occurred in North Carolina, a state that has invested fairly heavily in quality improvement. They have statewide safety programs and improvement collaboration initiatives, and they saw no change. Now, while they concluded that the harms remain common and that further efforts are needed to translate effective safety interventions into routine practice, I had the opportunity last year to see Tom Naska of the ACGME speak to the Council of Residency Directors, and he gave a different perspective. He talked about the average lifespan of a physician being about 30 years. If this is the case, then in the 5 to 10 years that the study occurred in, essentially 10 years past the publication of the AIR's human report, they should have seen roughly 1/3 of the workforce turnover being replaced by the latest and greatest minds in medicine. The fact that there was no improvement noted in the study, despite this heavy investment in quality improvement, shows that clinicians entering medical practice are simply not prepared to make care safer or to improve their own practices. It is my hope that your experiences as a witness of medical error and your intrinsic desire to improve the care that you give will be stimulated by this course. Over the next several lessons, we will review factors related to emergency medicine, how errors occur, and then we'll go through a sampling of tools that can help you take your game to the next level. So please join me as we explore quality improvement from an emergency medicine standpoint.